पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
भारत माता की जय. Now I would request our Chairman Scientific Committee, Dr. Preetam Samant, to please introduce our esteemed faculty.
Thank you, Dr. Malik ma'am. We have a galaxy of glaucoma experts with us today, and with their experience and wisdom, I'm sure we are going to gain and take home a lot of good points. The first person I would like to introduce is none other than my mentor and teacher, Dr. Varun Kumar Naik. Sir is the head of ophthalmology department at PD Hinduja National Hospital. He has, for the last 3 decades, 30 years, more than 30 years, he's been a postgraduate of the prestigious RP Center of Ophthalmic Sciences, All India Institute of Medical Sciences, New Delhi. And his area of interest is mainly anterior segment and glaucoma. But however, having said that, he firmly believes that everyone should first be a comprehensive ophthalmologist, even in this era of super specialization, which I must agree is a correct thought. He is presently the president-elect of All India Ophthalmic Society and the honorary secretary of this step. He has been the president of our own Maharashtra Ophthalmic Society and the president of Bombay Ophthalmic Association. In the past, he has been the secretary of All India Ophthalmic Society from 2014 to 2017. Needless to say that he has multiple publications in various peer-reviewed journals and has conducted many instruction courses over the years. I think his research methodology workshops, which he started, was one of the milestones of academics in our country. Nobody can deny that, and I think everybody who has attended it has definitely his praises for that aspect. He has many awards to his credit, and some of the notable ones are the International Master Teacher Award. He has won a gold medal from Bombay Ophthalmic Association, and so on. So I welcome Dr. Varun Kumar Naik sir, and his topic for today would be initiating glaucoma therapy. Put on your thinking caps. Our next faculty speaker is none other than Dr. Ronnie George. I've had the fortunate, I've been lucky to have worked with Dr. Ronnie as a colleague way back in Shankar Netralaya. Dr. Ronnie George, besides from being a fantastic clinician, an excellent academician, I would say he's a great human being. We welcome you, Dr. Ronnie. Dr. Ronnie completed his medical studies from St. John's Medical College, Bangalore, and his post-graduation from CMC, Bangalore. He then joined Shankar Netralaya, and he's deputy director of the glaucoma services at Shankar Netralaya. He has trained over 60 glaucoma fellows at Shankar Netralaya, besides being a guide for PhD and the DND programs. Again, he has multiple publications in both peer-reviewed and non-peer-reviewed journals, many articles in books, many chapters in books, various lectures and various instruction courses. Some of his accolades, some of his awards include the Kumaraswamy Gold Medal by the MGR University during his MS Ophthalmology, the Thomas Gold Medal for the Best Outgoing Postgraduate from CMC Vellore for the year of 2001. He's won the Pfizer Best Paper Award for the best paper during the annual GSI meeting of 2003. He has won the IGO Silver Award for the best publication in 2009. He has in the past been the Associate Advisory Board member for the World Glaucoma Association and has also been the Secretary of Glaucoma Society of India. Dr. Ronnie's topic for today is pre-parametric glaucoma diagnosis and management. After that, we have with us Dr. Sushmita Kaushik from Chandigarh, and her topic for today is going to be combined surgery, strategy and optimizing outcomes. Welcome, Dr. Sushmita. Dr. Sushmita is a professor has been MD professor. She has completed her ophthalmology from the Maulana Azad Medical College and her senior residency from PGI Chandigarh in 2004. Her research interests include newer diagnostic tools, childhood glaucoma, angle closure and glaucoma surgery. She has almost close to 100 publications in various journals. She has chapters in various textbooks, mainly including glaucoma chapters in various textbooks. She has been the former secretary of the Glaucoma Society of India and is currently the secretary of the Indian Pediatric Glaucoma Society, IPGS. Among her special honors include being member of the Worldwide Childhood Glaucoma Research Network. She is a member of the Task Force Glaucoma for the Government of India. Again, she has various awards to her name, notably being the D.V. Chandra Award for Best Glaucoma Paper of the AIOC Bangalore in 2008, the Best Scientific Papers at the annual GSI meets of 2004 and 2007. You know, one secret I would like to tell you about Dr. Sushmita is that she's an avid music lover, and she likes various genres of music. She also enjoys all forms of performing arts and has been an avid debater, elocutionist and actor in school and college. Probably we'll get to see that part of Dr. Sushmita in some of our other webinars, non-ophthalm webinars that we have. And last but not the least, we have none other than Padma Shri Dr. Harsh Kumar from Delhi. He was awarded the Padma Shri in the year 2015. He's been a gold medalist in his undergrad days from the All India Institute of Medical Sciences, and his post-graduation also was from the same reputed institute, the RP Center. He has passed out with the Bodhraj Savarwal Medal during his post-graduation. He has been formerly the additional professor of glaucoma in the glaucoma unit of the RP Center. He has also been the president of the GSI in the years 2010 to 12. He has more than 70 publications in various index journals. He has to his credit several laser procedures for glaucoma and anterior segment procedures which were described for the first time in world literature. One of his, in fact, procedures has a special mention in the Shields textbook of glaucoma. He has conducted numerous courses at the AIOS and the DOS annual conferences, and he has performed some of really complicated glaucoma procedures using some of the latest technologies, procedures involving shunts and glaucoma valves. Again, he has numerous awards and honors over the years, some of the notable being the International Medical Scholars Program Award and the Fellowship Award at the University of Illinois at Chicago. I welcome Dr. Harsh Kumar today, and he's going to join us shortly. And his topic for today is Pearls of Glaucoma Management. So these are our 4 speakers for today's evening. And now I give the task of introducing our 2 moderators to Dr. Santosh Bide, sir.
Thank you, Dr. Preetham. Good evening, everybody. Today we have 2 gems from our Maharashtra Ophthalmological Society as a moderator for this session. The first one is Dr. Ashish Thul. He is a practicing ophthalmologist from Nagpur. He has done his fellowship from Shankar Netralaya. After completing fellowship, he was a consultant at Ganpati Netralaya, Jalna. He was a president of Nagpur Academy of Ophthalmologists. He is an incoming president of Vidarbha Ophthalmological Society. He's also on advisory board of Ophthalmological Society of Nagpur, and he's a managing committee member of Maharashtra Ophthalmological Society. He has many publications in peer-reviewed journals. The second moderator is Dr. Preeti Kamdar. She is a practicing glaucoma specialist from Mumbai. She has done her graduation and undergraduation from Sai Hospital, Mumbai. After that, she has done her fellowship in glaucoma from LV Prasad Hospital. She has keen interest in angle closure glaucoma, neovascular glaucoma, and diabetic retinopathy and glaucoma. She is a very popular teacher also. She likes to teach postgraduate students and has she is also a member of Bombay Ophthalmological Association, Managing Committee of Bombay Ophthalmological Association, and she is a reviewer of JCOR. Now I request Professor Sunaina Madam to start the webinar.
Thank you, Santosh. I would now request Dr. Barun Naik to please start his talk. Thank you, Barun.
Thank you, everyone. I'll first share my screen.
I would also request everyone else other than the speaker to please mute themselves and shut off their videos.
Yes, so now you can see this.
Yes, absolutely. Yeah. Perfect.
Okay, and my time is 10 minutes, already 5:12. Okay, so now I am going to talk something about initiating glaucoma therapy. Put on your thinking cap. Now, basically, this talk is directed towards the comprehensive ophthalmologist. It is not for the glaucoma specialists, because all of them, whatever I am going to talk, nothing great. It's all simple things which is always being ignored, and which everyone should take care. And as a matter of fact, more glaucoma patients are being treated by comprehensive ophthalmologists rather than glaucoma experts. Glaucoma experts take care of more complicated cases. So that is the scenario. In that case, this talk becomes very important. Now, the goal of glaucoma therapy is to maintain useful vision till his, her, or lifetime with acceptable alteration of quality of life. Means in this, it means we cannot, means in his lifetime, we have to maintain useful vision. It's not that the normal, whatever vision is there, that we have to maintain. So that is a fact of life in glaucoma treatment. And second, whatever treatment we give, always there is a quality of life which is affected. So there has to be a balance between both these two. Now, glaucoma, we have to understand, whenever we start a treatment, it's a chronic disease. Majority are asymptomatic. Lifelong management is required, just like diabetes or hypertension. It can be controlled but cannot be cured. Again, just like diabetes or hypertension. Difficult for patient to realize the benefit of treatment, because we feel, oh, it's very nicely controlled, but patient feels that I am not seeing any difference. Surgery we do, we say that, okay, fantastic blood pressure is very nicely controlled, but patient says, doctor, but my vision has gone down and I am always getting irritation on the upper part of the lid. So those things we have to understand. Patients are often frightened by the diagnosis. Merely giving a diagnosis of glaucoma influences his or her quality of life negatively, and it may even lead to blindness, even the treatment. So that fact also we have to keep in mind. And this fact is also important. Why this talk is again important? Because 50% of glaucoma patients either do not need treatment or are being over-treated. This is based on research. And how does it affect? The higher cost affects quality of life. More treatment, more medication, it affects quality of life more, and risk of side effects. More medicine, more side effect. And also it leads to high percentage of non-compliance, which is a very important aspect in glaucoma management. Now, whenever you are managing a glaucoma, especially in starting the treatment, first of all, establish a diagnosis. Just not in first examination, anyone can say patient has glaucoma and I have made up my mind what treatment to start with. Second, establish a good baseline intraocular pressure, and means not only intraocular pressure, establish a good baseline parameters. Now set a target IOP, then initial therapy and attempt to lower intraocular pressure to target, and then follow up quality of life and some of the mistakes that we have to take care. But follow up will not be covered in this. Establish a diagnosis. I will not go in detail, but whatever the comprehensive examination of the eye has to be done, plus the proper optic disc evaluation, automated perimetry. The other things are optional. If you have facility, you can use it. If you don't have, don't bother about it. Then establish a good baseline parameter, especially the intraocular pressure and perimetry. And remember that every time when you do perimetry, and also in this one aspect I have missed out, is the disc evaluation. So every examination, intraocular pressure, disc evaluation and perimetry to be done and thoroughly. So that's why the baseline has to be thorough. Then only you will compare what is happening in due course of time. But remember these two things, intraocular pressure and disc and perimetry, these two things serves two different purposes in follow-up in glaucoma management. Intraocular pressure tells you only that whatever treatment you have instituted, whatever intervention you have done is effective or not. If it is effective, then in follow-up you will come to know by evaluating optic disc and perimetry that my treatment was sufficient or not when I started. So, or I have to do something more. So this difference you have to remember. Now, target intraocular pressure that we set in before starting treatment is the mean intraocular pressure obtained by treatment that prevents further glaucomatous damage in the eye of the individual under consideration. And in this, again, this I am repeating every time that my professor L.P. Agrawal always used to tell us no medication is the best medication and least medication is the best alternative, because more you treat, more side effects. So above all, do no harm. And this I will bypass. And target pressure you should remember, because sometimes I have seen prescriptions right in the beginning. Patient comes and first day examination and 2 medicines, 3 medicines straight away started, which one should never do, because you don't know whether the patient, because least medication is the best alternative. So least medication, if you start 3 medicine, how do you know which medicines were really important and was necessary? So unless you go step by step. And also remember that if you add too many medications, then as per the European Glaucoma Society guidelines, it is unlikely that more than 2 pharmaceutical preparations with maximum of 3 active molecules are going to be effective, additive, well tolerated and reliably taken by the patient. Therefore, restrict yourself in giving prescriptions, that how much prescription you are giving. Now, this already I have explained about follow-up, which anyway I will not cover. Then quality of life also has to be considered, because quality of life is any glaucoma patient, it gets affected just merely by diagnosis. That patient mentally he will be upset that now I have got this disease, lifelong it will be there, I may lose vision. The second aspect which affects quality of life is the treatment itself. The regular pattern that every day you have to use medication, that idea itself affects quality of life. Then the cost factor also affects quality of life, and some of the effects of medication, everything affects quality of life. So this also you have to consider about when you are starting a treatment in glaucoma patient, because first time you are starting. Now this algorithm is looks complicated, but it is from the European Glaucoma Society guideline, very simple. Always start with monotherapy first, and then you will not be over treating ever. So if it is effective on intraocular pressure, then and if target IOP is reached, then continue and monitor whatever you want to monitor. The second option may be that it is not effective. If it is not effective, there is no point continuing this medicine. Then you change this monotherapy and again follow the same sequence. It may be not effective or it may be effective on IOP. If it is effective, fantastic. If suppose the target IOP is but target IOP is not reached, effective, but target IOP is not reached, this is the time that you can add the second medication. So like this, if you follow, if you go step by step, then you will not be over treating patients. And this again in follow-up sometimes, because not during initial period, but that if patient deteriorates in spite of control of IOP, then just keep checking these things that probably you are missing out diurnal variation, compliance, systemic features, maybe dealing with something different. And if everything is ruled out, and also consider CCT if you have not done so far, and if everything is ruled out, then probably the time for further increase the medication or intervention. Now this prescription is my favorite prescription because you see so many things are written in this, and this prescription was written for the first time. Just imagine a patient came to for examination and diagnosed glaucoma and started like this. Now what are these? Cap, Lacryguard, then Cystine, Erivex, Refresh and Lacryl. 5 types of lubricant. And Zalatan, the left eye in the morning, Luvigan, left eye at bedtime. Now what is the point in giving same class of medicine to different company in the morning and evening? So these things, if you start, how many of us can follow the schedule even for a week for a disease which has got no symptom? And always remember that there are only 2 types of medicine in primarily in glaucoma. One is it which controls which reduces the aqueous outflow, and other one which enhances the outflow. So if it is inflow so whatever medicine you are giving, the first combination should be, if one group we have given this, then the combination should be from other group. After that only you try to come with, then there is no option. You have to, if your third medicine you are giving, then there will be overlap. If angle closure glaucoma, then consider laser PI wherever indicated before doing anything. Then you proceed and treat just like open angle glaucoma, and consider lens extraction only in select cases, but for specific reasons for that. And these things also you remember that you are not misdiagnosing and not missing out, because many times the patient may not be having glaucoma at all, something neurological problem, and patient, because ophthalmologists, if some kind of field defect, always they think, no, it's a glaucoma, start treatment. And pressure is, by chance, if it is little in means 22, 23, 24, then they think it cannot be anything else but glaucoma. So remember, but these things will not come in the beginning, because in follow-up, red flags, loss of visual acuity, unless it's a central visual acuity, unless it's advanced stage of glaucoma, then something has to be there. If the central visual acuity is also affected, something else than glaucoma, cup to field mismatch, hemianopic visual field loss, rapid progression, pallor more than cupping. So these things are there, then you have to be careful. And always remember, hemianopic field defect is something which we have to remember, that hemianopic field defect is not glaucomatous. It is neurological in optic pathway, in chiasma and beyond up to the occipital cortex. So time is short, so I will not tell you about the RP Mills criteria, but remember that sometimes the subtle hemianopic defect also can be there. So you have to pick up and don't consider this as this any field defect means glaucoma. Now this is very simple case. This is the left eye, right eye, and there is no confusion. It is bitemporal. And this is the disc, which is again bow tie type of optic atrophy, temporal and nasal. So the glaucomatous will be on upper and lower, which is not there. So it's a straightforward, and diagnosis is also a straightforward, but it's being presented for some reason. Now this was 2 years before the field of vision. Now this eye is still having, the right eye has hemianopic defect, temporal. This one only few points on the temporal half missing out. This time also doctor should have picked up. This was 2 years prior to that. Right side, left side absolutely normal. Right side, some points on the temporal half respecting the vertical meridian. This is the time we should pick up that this is not glaucoma, and we have to see that it is neurological, which was the case. Now, 2022 pressure and perimetry was not done. Only GDX VCC done and diagnosis of glaucoma done based on this disc evaluation, which was suggestive of glaucoma, but perimetry not done. What was done? GDX VCC. All parameters as per the company's recommendations, everything is showing affected. So it started on treatment, but does it confirm the diagnosis? Now when patient went to other doctor, came for second opinion, bitemporal hemianopic defect, nothing else to be done. And remember, every time I have seen that now, because the companies always, whenever they start treatment, always they push in some kind of lubricant also, which is really not required, because if there is dry eye, if patient is having some symptom of dry eye with treatment, it can be coexisting, it can be developed after treatment. If that is the case, you do that, but not in the beginning. And always remember the patient's perspective also, because patient also expect that what is their perspective. So maintain patient's anatomy autonomy. So 5 questions must be answered. What is the effect of glaucoma on patient's ability to work, quality of life? Understanding the disease, because it's a chronic disease. Patient has to use treatment lifelong. Unless you have spent table time with him, he will not understand properly. Side effects of treatment and how to tackle them, because definitely there will be some side effect, maybe minor, maybe major. Using medication for long, so compliance, adherence and persistence also has to be, because this is from the patient side. So unless you explain, it will not be possible to get all these cooperation. And cost of treatment also you have to consider. So those things we have to, if you do that, then your patient will be really a happy patient and your relationship will be happy. Now, this treatment, when you are starting medication, then in the beginning, say these are the various patients, because all patients don't behave same way. Their progress, all various curves are given. So based on that, in the first time when the patient has come, we will never come to know that what is the behavior of this patient going to be, the intraocular pressure and this patient's course. So that in due course of time only you will come to know. So always your aim is to prevent the patient from unnecessarily moving downwards, and definitely it should not move into this red zone. And this is the for target pressure that you decide those glaucoma damage, that how much is the glaucoma damage, means the rate of progression you cannot come to know in the beginning, but other 3 things, that the amount, what is the amount of damage, what is the life expectancy of the patient, and what was the treatment, untreated IOP where the diagnosis was made. So based on that, if damage is early, life expectancy is short, untreated IOP high, then target pressure can be set up little high, but otherwise if opposite the case, then it should be low. And so this is how we should incorporate into this. And follow-up is important for further course, because in the beginning, the problem with target pressure is that you have to decide beforehand, but you will not come to know that time whether it was sufficient or not unless you have followed up this patient properly. So if it is like this course following, fantastic, just maintain therapy. If like this course, then you have to think something that I might have to step up. If this is the case, some radical change has to be done. And always remember that all new medications which are introduced into market, everyone jumps into that they think that this is something which is God-sent medication, and I can treat any type of glaucoma, and this is wonder drug. It is not the case, especially when the combination of brimonidine and CA inhibitors came. Everyone started using as the first line of treatment. But remember, none of the medicines of these 2 combinations is first line medication. This is where it is used. If first and second line of medications are either intolerant or side effects are there, or sometimes if everything has been exhausted, then you may try that some critical 1 or 2 extra millimeter that you want to put it down. So just if you follow these guidelines and some fact if you keep in mind when you are treating, I am sure you will be better off, and you will not be unnecessarily over treating patients and causing and affecting quality of life to the patient. Thank you very much.
Thank you so much, Varun. That was a very elaborative talk and exactly what I had wanted, in order to, that we should not be labeling a patient as glaucoma unless we are absolutely certain of it. Because as you said, it has a huge impact on their psyche. And later on, when we are discussing it, I'll talk about that. Now, I request the next speaker, I think Dr. Ronnie George, to please start sharing his screen.
Yeah, I have unshared it. So now, yes.
You want to say something, Varun?
No, I said I have unshared my screen. So now it's already there.
Thank you, Dr. Sunen and Dr. Preeti for the invitation, and Dr. Preetham for the kind words. I'm going to speak to you about preparametric glaucoma, its diagnosis and management. So preparametric glaucoma is defined as the presence of characteristic optic glaucomatous optic disc and nerve fiber layer damage in the absence of visual field defects on conventional achromatic automated perimetry. So what this means is Conventional achromatic automated perimetry is done on a standard machine, of which there are 2 or 3 different versions available in the market. And that is something that you should keep in mind. And this is because when you look back at Quigley's old paper, he suggests that for a visual field to have a 5 decibel loss, you need to have 20% ganglion cell loss. And the structure and function change is sort of curvilinear, with structure changing earlier than function. And if you look at this example of an early glaucoma, here you're seeing early change there. You're seeing some change on the OCT, and you're also seeing similar change on the visual field. But this does not always happen the same time. And in fact, if you look at the ocular hypertension treatment study, which essentially looked at ocular hypertensives who were treated versus untreated, and looked for follow-up over a 5-year period, when you look at the progression here, you find that the majority of patients who progressed actually progressed with the optic disc only. And that is because this is early in disease, and you can get progression early in disease, which is better picked up, which is more likely to be apparent on a structural evaluation. The other reason why this happens is because threshold determination on visual field testing is fairly variable, and that can sometimes be a bit of a problem. So I'm going to share with you a clinical scenario where the intraocular pressure is normal, the disc is suspicious, the visual fields are within normal limits, and you have a doubt about whether this is preperimetric glaucoma or not. So in a situation like this, you have to assess the risk based on a careful disc evaluation, and you have to classify that disc as being low chance of preperimetric glaucoma versus a high chance of preperimetric glaucoma. So when you do a careful assessment, if you look at this disc pair, you can see that there is cup disc asymmetry, and there is definitely enlargement of the cup. There's some inferior thinning. There is a nerve fiber defect, and there is a disc hemorrhage there. So this is a disc. This is a disc which ticks all the boxes. Based on a clinical evaluation itself, you can be fairly sure that this patient requires further evaluation for glaucoma, and the suspicion of glaucoma is pretty high. So if this patient has a normal visual field, this is somebody with preperimetric disease. Before you decide on this, every disc should be critically evaluated for size. For example, this disc looks like it has a large cup, but it's also a large disc, and the rim is fairly healthy. So this is a disc which is suspicious only because of an anatomical reason, and therefore the risk of you would be unlikely to classify this as a preperimetric glaucoma. And don't forget that any disc which has abnormal structurally because of anatomy can always be a little difficult to diagnose. But in the presence of a structural defect, you can be suspicious, but you're unlikely to label this as a preperimetric glaucoma because it's a tilted disc with a fairly healthy neural rim. So again, the risk of glaucoma in such a disc is low, at least at this clinical evaluation, if everything else is normal. I'm going to give you another clinical scenario. You again have an intraocular pressure which is normal. The disc is suspicious. There are disc changes, and there is RNFL thinning on the OCT. Now, with the OCT being more easily available, many of us, when we get our suspicious disc, ask for a OCT, and sometimes it adds to the confusion instead of solving the confusion. The visual fields here are also normal, and how do you decide about preperimetric glaucoma? So I'm not going to go into details of OCT evaluation, but to just tell you that one important thing is you have to understand the OCT has its own issues. You have to make sure that it is there are no artifacts, it's a good quality scan, and that includes centration, quality score, and other things. For example, this patient who was being treated for glaucoma essentially had an issue with centration, and when the test was repeated post good centration, the OCT was absolutely normal. I'm going to share with you a few cases. This was a 52-year-old man who was advised glaucoma treatment elsewhere. His intraocular pressure and Paki were in the normal range. His disc was suspicious and visual fields were within normal limits. So this is what his disc looks like. Definitely a largish disc, and you can see that maybe there is some thinning of the superior rim, but the NFL looks okay on a referee photograph. The left eye is also a large disc. There is some inferior peripapillary atrophy. NFL again looks fairly okay. You look at this, you're definitely seeing some red disease on the OCT, on both the disc and the GCC. But look at the size of that disc. The disc is really large, 2.67 and 2.79 millimeters square. And this whole box is grayed out over here and over here. When it is grayed out, it means that the OCT does not actually have normative data in this range. So most of your classifications in this range have to be taken with a pinch of salt. And we established that this is a large disc, And we established that clinically we really did not see anything much on the disc or the RNFL. So I would put this again as being a low risk of preperimetric glaucoma, and I would probably just follow up the patient. So remember that imaging has its limitations when it comes to anatomy and when it comes to its normative database. This next lady was 59 years old. She came for presbyopic glasses. She had no significant positive history otherwise. Her intraocular pressures were 18 millimeters of mercury in the right eye and 19 in the left eye. And central corneal thickness was near normal with open angles. This is what her disc looked like. A fairly healthy looking disc. On red-free photography, you're seeing some amount of maybe RNFL loss there. The left eye was also looking slightly larger than the right eye, and you're definitely seeing some RNFL defects there. Visual fields were absolutely normal, except for a few points here which really didn't meet Anderson's criteria. But the OCT showed some small nerve fiber layer defect here. In the left eye, the right thinning that we saw on the disc photograph was actually not seen here. And here your risk is a little, your clinical suspicion is a bit high because anatomically everything is fine, but your clinical suspicion of seeing a change on the optic disc is, and you're seeing something similar on the OCT, even though the visual fields is normal. And if you look at the GCC here, you're seeing a temporal raphe sign. So this temporal raphe sign where you're seeing this abrupt cutoff, abrupt thinning, which respects the horizontal midline in the temporal field, is fairly suggestive for glaucomatous damage. So don't forget that glaucoma is a progressive optic neuropathy, and preperimetric disease should ideally progress to perimetric disease. And I'm going to share with you a paper which looks at how good is the OCT at detecting preperimetric disease that progressed. So this is a paper from Bob Weinreith's group, where they followed up people who are normal, ocular hypertensive, and glaucoma suspects, followed up for at least 2 years. Some of these progressed to early disease, and they looked at both fatalis and cirrus, and to compare what happened, how the imaging was at baseline compared to in the patients who progressed versus the patients who did not progress. So basically, out of these 300 odd eyes, 154 eyes did not develop visual field damage over follow-up. 34 eyes developed visual field damage over follow-up, and I'll show you this in a little bit more detail. When you look at the sensitivity and specificity of the OCT in detecting damage here, you find that it was sensitivity was actually very poor. For both instruments, it was between 23.5 and 32.4 when you looked at a global RNFL being outside normal limits. If you had more than one RNFL sector, which could even be just one clock on the OCT being abnormal, at baseline, even then it was just about 50 to 52% of sensitivity. So the OCT also found it difficult to differentiate between patients who are likely to, with suspicious discs, who progress to disease over time. So a true perimetric disease, you need to rule out a normal outlier. You need to rule out an anomalous disc. You need to rule out a non-glaucomatous cause. Dr. Burden showed you nice examples of that. And you need to rule out an artifact on the OCT before you define that patient as having true preperimetric disease. What about treating preperimetric glaucoma? Here now you need to bring in one more condition, and that is once you have decided that risk based on disc is significant, you can look at the additional risk factors before deciding on treatment. And they would include age, family history, inciting cause, was there some trauma, was there some history of steroid use, and the intraocular pressure. We'll come to the IOP last. I'm going to give you the same case, but I'm going to alter a few parameters here and there. So this was a 37-year-old who came to us for a routine evaluation. He was a myope. And in the first scenario, he had open angles on gonioscopy, DVT IOPs was 16 to 18, and PACI was 520 to 524. Visual fields were within normal limits. This is what his disc looked like in the right eye. This is what the disc looked like in the left eye. And on the RNFL red-free picture in the left eye, you can actually see nerve fiber layer defects. So in scenario 1, he's 37 years old. And could this actually be a preperimetric NTG? Because his DVT is fairly normal. His PACI is okay. So now the issue here is, at the age of 37, we rarely see NTG. So it's most likely that we need to look for a cause for that nerve fiber layer defect. But I would hesitate to start on treatment. I would keep the patient under follow-up, and I would not treat. But suppose this patient had a family history of glaucoma. My index of suspicion now goes up. And I would consider keeping him under even closer follow-up. And at the slightest suspicion, consider treatment, because this is how you are assessing a different risk parameter each time. Look at the third scenario. If the same patient was 63-year-olds with the same findings, here a diagnosis of NTG is possible, and you're seeing a nerve fiber defect. If there's no other reason for the nerve fiber defect, you could consider initiating treatment in such a person, depending on a discussion with the patient. And I'm going to, what about intraocular pressure? So if intraocular pressure is normal and the disc is really suspicious, you're essentially looking at a pre-parametric NTG, and you should do multiple intraocular pressure readings before you decide on doing anything about it. And you should also take a good history to rule out something like a vascular compromise in the past. What if the intraocular pressure is high? If the intraocular pressure is high and the disc is very high, suspicious, this becomes essentially a high-risk ocular hypertension, for which guidelines are fairly standard that you would consider treatment. So why should we not treat all pre-parametric glaucoma? And the reason for this is, even though it's well proven that all the studies have shown you that reducing intraocular pressure actually reduces risk of progression, but does lowering IOP in eyes with NFL defects prevent progression to glaucoma? That question really has not been answered. So we really don't know what happens with disc suspects. Dr. Barun has already spoken about glaucoma medications and how they can be problematic. In fact, this little study, which looked at the intensity of side effects on topical medications, found that 80% had some issue or the other 2 months or after starting medications. And he also alluded to quality of life. Both medication and surgery do affect quality of life adversely. Our aims of treatment, as Dr. Barun Naik said, was to preserve vision and to maximize quality of life. And if that is the aim, and you're having somebody even with just ocular hypertension, Quigley actually said that the average life expectancy for an ocular hypertensive after diagnosis is 25.5 years. And when they modeled this and they looked at the risk of blindness based on other longitudinal studies that have been done. So if you look at 15 years from the time of diagnosis, the risk of blindness is actually very small, 1.5 and 2.6% for somebody who had no visual field defects at baseline with a raised intraocular pressure if they were untreated. So we have to be sure of what we are treating. Are we treating the disc or the NFL or the OCT? Are we treating the eye, which is functionally fine because the visual fields are normal? We are treating the patient, and don't forget that glaucoma drugs are not pleasant. So it's important to do a risk-benefit analysis before you decide to do any treatment. And the risk-benefit analysis should be done after you rule out confounders, which can confound clinical evaluation. You should include age, history, intraocular pressure, and other risk factors like pseudoexfoliation or trauma or steroid use before making this decision. If you're still in doubt, you can wait and reassess. Glaucoma is a slowly progressive disease. You don't lose anything by waiting 3 to 6 months or 9 months and periodically seeing the patient. But you should explain to the patient in detail why you're doing this and what the potential risks of not treating the patient are. So in summary, pre-parametric glaucoma is always decided after a careful clinical assessment. Treatment is decided after a careful risk factor assessment, and it should be determined on an individual basis considering each patient's benefit to risk ratio. Thank you.
Thank you so much, Ronnie. That was very well done. And I think it made a lot of things clear for us. So now please may I request Sushmita to share her screen. We'll take Dr. Harsh Kumar's questions first because I believe he has to leave at about 6:15 or so. And then we can take the questions for the other speakers. So Sushmita, please.
Or do you mind if I speak first?
Do you want to? Okay.
Because I think medicine, everything was medicine, and that part is surgery. So it will be, if it's okay with you people.
We have no problems if Sushmita doesn't.
No, not at all, ma'am.
Please go ahead then, Dr. Harsh. Please go ahead.
Sure, Sushmita?
Oh yes, go ahead, go ahead.
Okay. Just...
Yes, sir, sure. Please go ahead.
Thank you so much.
Not at all.
Okay, are we, is it clear?
Yes.
Yeah, we can see it.
Absolutely.
The voice is clear?
Yes. Very clear, sir.
Okay, thank you. Okay. Okay, it's just a little potpourri, and I'm really sorry because I missed the first part because of some other meeting, but this is just for, I think mostly for youngsters, I want to say a couple of things. And most important is that please, you have to buy a gonioscope, which is an indentation flow mirror. You have to have your own indirect and your own 90B.
Dr. Harsh, please play your slides. I think it's not full screen, or is it?
Oh, sorry. Yeah, you are right. Yeah. Now it's okay?
Yeah, perfect.
Okay. So, because almost 30 to 40% of our patients are still angle closure. And the moment you don't have your own gonioscope, you are not used to doing a gonioscopy, you are going to miss this. My trouble is not that somebody else will pick it up and say, oh, what kind of a doctor is this, who has missed this gonioscopy. But the more greater trouble will be that the chances of going blind are at least 2 to 3% higher if you are an angle closure patient. And I always like to give a small example because it's always the stories which stick on. So I had a patient who was chronic angle closure, and he was controlled on 2 medication, moderate damage, so we thought all right it'll be. And 6 months down the line, he comes to us, one eye is PA negative. I was so shocked, what the hell happened? And then he told me, sir, what can I do? I'm from Meerut, and there were riots, and I could not get any drugs for 6 months. Now, this is never likely to happen in open angle glaucoma. So please be very, very careful not to miss angle closure glaucoma, not only because you're the PI has to be done first, but the treatment overall has to be more aggressive. And for the youngsters who are going to do practice, obviously, because nobody teaches us these things, that nobody taught me this in All India Institute, and it was really hard work learning all these things. That most important is your availability and behavior. Even if you have a 6-12 patient, and if you have been very, very good to him, he will not complain. But if your behavior is bad, a 6-6 patient will give you hell. You have to be sincere to the patient, and that all Indian patients are intelligent. They'll see you that in your eyes and in your work. You must have a personal rapport. Sit down, spend 5 minutes with the new patient, tell them, ask about their family, and remember that, make notes somewhere. So the moment somebody comes in and I tell them, oh, where is your daughter? How is she in London? And he's so thrilled, he sometimes forgets what he has suffered actually, what is the pain that is troubling him so much. Always praise the patient, never speak ill of his previous doctor. I'm really, really sad, and I'm also must admit that while I was sitting in an institution like All India Institute of Medical Sciences, it was very easy for us to say and say, "Arey, bhai, ye kya kar diya? What have you done? What has the doctor done for this patient?" Please, for God's sake, the sitting in an institution is entirely different than sitting in a practice when you are all alone, not being able to manage many things is totally different. So please, please never speak ill of another doctor. And many times the patient will tell, oh sir, unhone kya kar diya, bilkul kharab kar diya sir. So you have to specifically tell them, no, I don't think whatever he did was right. Maybe sometimes what I do is that if he's really done some blunder, I'll pick up a phone later, take his phone number and tell him, bhai kya kar raha tha yaar, pandas dilate karke to dekh leta kya pada tha. So yeah, or something like that. No, so please, whatever communication has to go directly to the doctor. But if it goes through that, and the patient goes and sues him, tomorrow he is quite capable of suing you as well. So be very, very clear about that. So many times we tell patient, "Arey bhai, tum to dawai nahi dali, you have not done this, that." They never take it rightly. So there are ways of telling things that, okay, I also forget sometimes, yeah, I know that you are not putting, so please. So we have to, after all, he is the king because he's coming to us. And so these are practice for, they are not for people who are sitting in institutions, because I know I have been there, and it's a different matter. We have to be very, very fast for the patients there. And never, please explain each test. I have seen people write 5 tests, and the patients just think that this man is out to take money. You have to sit down, tell them, fields we are doing, because we have to find out what kind of medications we have to take, what is the damage in your eye, and we have to compare further how the damage progresses. So every test has to be explained. Judge what the patient wants. Never be scared to refer. Never. I've referred so many patients and they have always come back and told me, sir, this is one of the finest things that you did for us, and they'll bring 10 patients to you otherwise. So please never be scared to refer. One of the other problems that I face is the moment people see this, oh my God, there's a large cup, and they will do all kind of tests. Please just have a look. Or there's no wedge defect. The isn't rule is being duly followed. Everything is good, and if you really look at it, it's just that this cup looks larger than the cup in the other eye, the disc in the other eye. So it is maybe a large disc will have a large cup, but they will always do a field which has turned out to be normal. Obviously, it had to be normal, and then they'll do an OCT, and you can then see in the OC that the disc is much larger in the left eye. But all you should have done that time was to put a person on the slit lamp, take the cross this thing, and multiply. If you have to use an entity, multiply by 1.3. All the slit lamps have this where you can measure the size, and then you can find out whether it is large or not. Especially the youngsters. I get so many 10-year, 12-year-old kids who are referred, sir, glaucoma. Please see, they have told glaucoma. 3 people have told glaucoma. What is happening is the child is so scared, it will squeeze and the pressure will come high. It will never come low. So you have to totally relax, and it's totally an art to do. I think Sushmita knows best. So there, what you have to do is immediately make the parents sit down. And sometimes what you'll find, the father is having the same kind of a test. So all it is that it's a physiological test. You want to investigate anybody, investigate the father, not the other thing that I was telling. So this guy, a 50-year-old male, comes across, everything is pretty much normal, and the pressures are also normal. He's got this field defect being treated for 2-3 years, and then you suddenly see that this field is just not looking like glaucoma. And what is happening is nobody is dilating. The diagnostic is normal, but you dilate and have a look what is right here or there. And you can see there is a patch of retinochrosis which is reflecting over there. It is a stable field defect. You put him off medications, nothing will happen forever. The only thing is you need to follow up with the retina guys. So please, for God's sake, always if you feel that the field defect is not accurate, not like a glaucomatous field defect, it's not a nasal step, it's not an arcuate defect, please go ahead, dilate, look for other causes. And this another thing, many a times this patient was referred to me. Obviously, he's got a thyroid ophthalmopathy, and they are so worried that he's being operated. Sir, pressure is 40, no medication is working. What actually is happening is the moment he looks, they tell him we want to do a pressure lookup. And what he basically has is thyroid ophthalmopathy and restrictive ophthalmopathy. So the thick muscles actually push this in and the pressure rises. All you have to do is, I use any of the things that you have or some of your friends have, there you do it, the pressure in the normal place where the eye is, and then you find that it is absolutely normal. There's nothing wrong. Or you can just get your slit lamp and do it. So you have to be very, very careful about it. I know beta blockers must have been covered by Dr. Nayak, but just 1 or 2 things I want to tell you, that we only ask for cardiac and pulmonary problems. But in children, what is happening is that in early parents will come more than 1 drop. And most of the time we are not telling punctal occlusion. In kids, it's a must. And a single drop could be can cause arrhythmias or brain strokes breathing. And the problem is, even when it goes to a pediatrician, he will never dream that this child is getting an eye drop. And most of the times, the parents will not be able to tell that. So please use butoxanol or even OD, mostly it works, and even 0.25 works well. You have gel formulation, obviously, and punctal occlusion is a must. Never to use brimonidine in kids. I think sir must have already told. Very, very important thing in pregnancy is what I am seeing invariably is even I sometimes get into real big soup that a patient of glaucoma and he says, sir, now I'm 6 months pregnant and I was putting all the medicines. And it's a shock that we never told them that the drugs have to be stopped. So what I've started doing is any girl in conceivable age above 18 to 19 years, I'll just write if you ever conceive. Don't ask whether they are married, unmarried, whatever, because that becomes a mess. So just any time conceive, please stop anti-glaucoma medication and come to me for further management. And we all know that Parametric is the only one which is safe, not fully, but that's the only one we can use others. But punctal occlusion is a must. And if obviously the ALT and SLT is one thing that must be used over here because it works well. But if it's a very mild damage, you can just leave everything and things will remain stable most of the times. But if it is advanced, then in the second trimester, you may have to plan a surgery. And obviously when Brimonidine we are using, please be sure that you stop this medication because a lot of people will then go on to lactation. And if they are giving the child milk, the thing will still cross over and create a big problem for you. So be sure about that. And a lot of us are not telling that the patient who's on Brimonidine can get severe allergies and a lot of somnolence. So many times I get, sorry, what medicine you have given? I am sleeping all the time in the office. So that is a big problem. I have already told this many times, but I'm still telling it. I have seen people use asazolamide right, left, and center. Oh, they're so scared. Pressure is so high. Use it 2 tablets 4 times a day. But actually, when you see the actual dose is not, if you give anything more than 250 QID, it's not going to work. So please don't use it more than that. The other important thing that that really changed my practice to some extent was there's so many patients whom you cannot operate because of certain factors. They don't want to get operated one-eyed. The pressures are plus minus on all kinds of medications. So there I just realized that people have been giving asazolamide for other things for a long, long time. So we started on half tablet BD, TDS, and we realized that if the GIT upset was not there, they were able to tolerate it. Liver function, kidney function that we do regularly were okay. Then yes, these people can do well for years on it without medications. And when we keep on, another story is that when we keep on adding medications, sometimes I also add 4, 5, keep on adding, and then suddenly one day allergy develops, you stop everything, and then you reintroduce one by one, and then you realize only 3 medications are working as well as the 5 ones, and the patient says, "Sir, ye kyun de rahe the mujhe itna sab?" So the medications which are coming at number 3 and number 4 are hardly reducing the pressure by 1 millimeter. Many a times they are not even reducing it for more than 6 months. So many a times you have to really sit down and see what you are doing. And obviously the more the medications we give, more the dry eye has to be really very, very important. I think Dr. Naik must have covered this, that we have now the Pasutin available, which is a ROCK inhibitor. The pressure lowering is not much, it's around 5.7 to 6. And invariably it cannot be used as a primary drug because it causes a lot of hyperemia, and these subconjunctival hemorrhages are not uncommon at all. But I must tell you that it is doing wonders for me because most of my patients are one-eyed, they are on full medications, and when I add this medication, yes, a lot of them become controlled. So it's something worth trying, because if it doesn't work, it doesn't work. But if it works, then it works wonders for us. And obviously, whenever the fields are still going down, you really do not know what is happening. The patient comes in, the pressures are all normal. You need to do a diurnal variation. And more than that, along with that, you need to do a 24-hour BP monitoring. Because if the diastolic pressures at any time are going less than 70, then we are in trouble. Plus, you have to ask them, are they having the sleep apnea? Are they doing some asanas or yoga, which can cause a real problem, and especially Kapal Bharti, Sarvangasana, Shirshasana. And a lot of them are doing a water drinking test in the morning. That is, they are using 3 to 4 liters of water in the morning. So what the hell will happen, obviously? So please, these are small biggest worry is that so many patients come to me referred from here, there, and sometimes not referred, but they come for a second or a third opinion. Hardly anybody has told them what is glaucoma. Nobody has told them that you have to come every 2 monthly for the pressure check, 6 to 9 months or 1 year for retest, and you have to follow up. Punctal occlusion has not been told, and Ramakrishna told me such a beautiful thing. He said, every new patient who comes to me, I tell him how to put the drop with my own hands and see him put the drop and tell him and teach him punctal occlusion right there and then. I think that's a wonderful thing that we all need to learn. And we also need to, a lot of youngsters do not do the healing part. They have come to us not for the medication, but for getting well. So please, you have to tell them that you'll be fine if you follow up regularly, if you keep putting your medication regularly. There's no question of your being blind. Do not read the net unnecessarily. I will take care of you. I think that is the most important thing that we need to tell them. Thank you very much for your kind attention.
Thank you so much, Dr. Harsh, for that talk, which was, I think, directed primarily at the newcomers who are going to start out in practice, because it was so explicit for them, the things they need to avoid doing, the things they need to do. And I'm so glad you emphasized that the patient comes to you not for medication, but for healing. And a doctor should be one, as my father was a general practitioner, he always used to say, कि ऐसे डॉक्टर होना चाहिए कि पेशेंट तुमको देखे तो आधी बीमारी उसकी वही खत्म हो जानी चाहिए. I think nowadays we are beginning to forget that aspect of medicine, where you need to be more than just a physician. You need to be a family doctor also. So I'm touch on that. Now over to you, Sushmita.
I'm sorry, I was in so much of hurry that I didn't thank you and the whole MOS along with PP for inviting me. Those standard points that I would say. And if somebody has a burning question, I can take it now. Otherwise, I think Dr. Nayak is more than, and Ronnie.
If there are any questions, especially for Dr. Harsh, we can take them before Sushmita's talk, because I think he needs to leave, possibly. Are there any, Preeti and Ashish?
Not specific.
Not specifically? Okay, then we go ahead. Okay.
Thank you
Over
so
to
much.
you. Thank you, Dr. Harsh, for coming. And whenever you feel comfortable, you can leave us. Over to you, Sushmita.
Thank you. At the very outset, thank you, Dr. Preeti, Madam, and MOS for this wonderful opportunity on Independence Day. So, Jai Hind to start with. I'll be talking about the choice of surgery in a patient with coexisting cataract and glaucoma. So there's no one answer at the outset. In the next couple of minutes, we'll look at an outline which has worked best for me. But as I always say, these pictures, this is the east side and that's the north side of the same mountain. It's Mount Everest. So the same problem might have different solutions, and it's best to take care of whatever works for you as long as it's working for the patient as well. So coming to cataract in a patient with glaucoma. Any cataract deserving to be out in a patient with glaucoma should be out. There's no question about that. It improves the quality of life. It optimizes glaucoma management by better visual field testing, better progression evaluation, better ONH, optic nerve head assessment and imaging. And in narrow angles, as we'll see subsequently, the angles are widened, the chamber deepens, and you might get a couple of millimeters of IOP lowering. So this young boy with steroid-induced glaucoma, you can see the posterior subcapsular cataract, and the disc is seen so hazily. And when it's out, you can see the disc that can be imaged, and the fields can be done so much better. So what are the situations that present to us in the real world? One is you might have glaucoma which is well controlled medically. That's good. But if the glaucoma is not controlled medically, or medications with side effects, and there's a cataract, that's a problem. So you might have an open angle glaucoma with the deep AC with advanced or moderate glaucoma. You might have a primary angle closure glaucoma, but the AC is not too deep post-LI with advanced or moderate glaucomas. Or you might have even PAC or early glaucomas with very shallow ACs and then many complicated situations. So the main thing to decide is the intraocular pressure and the extent of glaucomatous damage. That's what's going to decide what to do. If the IOP is controlled and there's only early damage, cataract surgery alone could be okay. But if the IOP is borderline with moderate or advanced damage, a sequential cataract and early trab would work well. You could do a combined surgery or a phaco-trab, but the trab of a phaco-trab is more likely to fail than a trab alone. So keep that in mind. If you have uncontrolled intraocular pressure and advanced glaucomatous optic neuropathy on maximum medical therapy, logically you should do a glaucoma filtering surgery first. Sometimes that gets problematic, so phaco-trab in this situation would be a better idea. The caveat is a phaco-trab is usually done in a patient who needs a trab but also has a cataract along with it. So this is the first situation of a glaucoma well controlled. Do a clear corneal phaco because you need to spare conjunctiva for future. One little bit is always use Diamox postoperatively even if the pressures were normal in the early post-op period, because there might be a spike and you don't want to damage an already damaged optic nerve. And please be sure to continue anti-glaucoma medications. Many times that's forgotten. So that's a caveat that should be done. Coming on to the problem of the PACG. So this pressure, very shallow anterior chambers. You can see the Van Herix is almost missing. These angles are closed. He also has a glaucoma flecken, which is not common, but I thought I put this up. These anterior opacities. And this picture is through the gonioscope, and you see the disc is not too bad. So you do have situations of acute rises of pressure where the disc is not very bad. This needs GFS, glaucoma filtering surgery, maybe if it's not controlled after the LI, but that's again problematic. So what is this to do with the clear lens extraction and primary angle closure disease? And especially after the EAGLE study, there's been a lot of excitement amongst people who think that just taking out a cataract is enough. So again, this is a situation of the two eyes of a same patient. You can see the right and left eye. The left eye has primary angle closure glaucoma as envisaged by this advanced visual field change, and the right eye has PAC, maybe with a few spots here and there. Both LPI is done, but if you see the anterior chamber, now this is the ASOCT and this is the cirrus. So the ASOCT shows you how crowded the iris is here. This is the lens, and this is the large lens vault. Now in this narrow angle, if you're going to go ahead and do a glaucoma filtering surgery as this person needs, that would be a problem. So the approach to this problem would be to take out this lens and see if the crowding of the angles here can be taken care of, and then, but this I would do a phaco first and immediately follow it up as soon as possible with a trab. And you need to tell the patient that I'm taking this, and you can see that the fact that you can see the disc so clearly that the lens is not particularly cataractous or there's not too much. There's a little bit of nuclear sclerosis here, but this lens is almost clear. But for these pressures, the approach would be a phaco for this and a phaco followed by a trab for this eye, because doing a cataract alone is not going to treat this glaucoma. Why am I saying that a glaucoma filtering surgery would be problematic? There is evidence that a GFS increases the risk of cataract progression. So if you already had a large lens, that would be a problem. And then there is a likelihood of the bleb function being compromised by subsequent cataract surgery. It's less with subsequent phaco than with an SICS or ECCE. So another caveat is, if both surgeries are required and IOP is controlled on Diamox, then there's a phaco first followed by a trabeculectomy. If the intraocular pressure is uncontrolled on Diamox also, then we go ahead and do a phaco trab. Now comes a position where there is glaucoma, well controlled on medication, but as Dr. Harsh was showing, very bad ocular surface because of long-term glaucoma treatment. Now, in ordinary terms, with a disc like this, an ocular surface like this, just stop the medication, give them a washout, put them on Diamox and do a trial. When we look at the anterior chamber, however, look at this cataract. Now this lens vault is pretty much, it's 897, nearly 900 microns. The anterior chamber depth is only 1.8 and the anterior chamber area is just 12.9 millimeters square. So it's a really small anterior chamber. And if I'm going to go and do an outflow procedure in this eye, I can be sure to land up in more problems than anything else. So we did a phaco first, and I just show you the same eye. If you 15, because now there's an intraocular lens rather than the large cataractous lens that was there. The anterior chamber depth has increased from 1.8 to 2.9, and the area has increased from 12.9 to 21.07 millimeters. Now for this disc, going and doing a trabeculectomy later is going to be much easier. And this is the same thing we're going to try for this eye, because there's no way that this patient is going to be able to continue putting his medications in these eyes. So I'm going to crystallize some thoughts on lens removal in primary angle closure disease. The level of intraocular pressure lowering after cataract surgery is proportional to the preoperative IOP and to the resultant angle widening after surgery. Patients with the narrowest angles preoperatively might be expected to benefit the most from cataract extraction as a single procedure, provided the angle has not become permanently closed with peripheral anterior synechia. So that's the caveat. There's no way that removal of a lens is going to treat your glaucoma in primary angle closure if you have synechial angle closure also. So keep that in mind, and the importance of a gonioscope, as Dr. Harsh said, is even more important. Coming to the phaco trap, whether we should do a single site or two site, there are prospective studies comparing the two procedures. The two site has a slight advantage, about a couple of millimeters more of IOP reduction, and they required less post-op medications, probably more to do with manipulation at the trabeculectomy site, causing more inflammation. So just a quick thing of how we do the phaco trap. The caveat is that you need to make your scleral flaps in a formed eye and do the phaco before entering the eye. So once you made the scleral flap, the next thing, now this is superior, so this is temporal. So you shift sides, you go temporally, take out the phaco, take out the lens, put in your intraocular lens, insert pilocarpine, and then go on and do your trabeculectomy. So here you can see the scleral, the punch is being made, the punch is being used to make the sclerostomy. That's the PI. And then be sure that you have a good conjunctival cover. Since we are doing a phonics-based flap, I like to anchor it amongst the peripheral clear cornea and have about a millimeter or so of the cornea covered. And that ensures even there's a little bit of retraction, there's no leak at the end of surgery. So we'll go on to sometimes complex situations which you really need to think of what is best for the patient. So this is gifted by our cornea colleague, a nice clear optical penetrating keratoplasty done. And these are what the discs are like. You can see a very, very large cup and an advanced glaucomatous damage, and the left eye seems all right. Now the pressures were 62 millimeters of mercury. The lady is completely intolerant to Diamox, and with glycerol and topical AGM, the pressures came to 50 millimeters. On careful examination of the other eye, it's actually a primary angle closure as well. Now she needs a glaucoma drainage device, but the problem is with this sort of eye, where do you put it in? There is no anterior chamber in the periphery. And if you look at the ASOCT finding, this iris is completely stuck to the host cornea. So this is the host cornea and this is the graft and this is where it is. So till here, there's the iris. Now if you think you're going to be able to put in a GDD into this little space in the chamber, it's going to be disastrous. So even though this lens is not particularly cataractous, for me to be able to put in a tube of a glaucoma drainage device over here, I need to have this lens out. And so we sent her back to the cataract surgeon to do the honors in taking out the cataract in this difficult case. Do the phaco first, make a space, and now that the cataract is out and there is enough space, now all of this is space. This is the IOL. So we have so much of space to put in the tube in the sulcus, and we'll just have a little bit of it peeping through so that we can see the tube and yet it doesn't obscure the visual axis. Sometimes, now this patient, you have a trap done, you have uncontrolled pressure, and you have a cataract. So now what? So this lady, I remember, came from Kashmir actually, one of the outreaches of Kashmir, 2 surgeries done in both eyes, failed traps, and a vision of 660 in one eye, counting figures in the other, 40 and 36 millimeters on maximum medication, and an advanced glaucomatous optic neuropathy. You can just about see the disc through this hazy cataract. So the best chance for this patient, you can't go in and keep doing trabeculectomies. The best chance that this patient would have is a phaco AGV, not sequential because she's not controlled, and also because she comes from so far. So the principles of the phaco AGV are the same as that of the trab in the sense that you insert the plate before entering the eye and then just go and do your phaco, but be sure that the entry is away from the site where you would put in your tube. And once you take the lens out and put your intraocular lens in, right, the next thing you need to do is insert the tube after IOL implantation. So in this particular patient with so many surgeries, the iris didn't really come down. So this is the tube that goes in after the IOL comes, and be sure to have a patch that covers the tube and then have adequate conjunctival cover. The conjunctiva really is a very, very good friend of the glaucoma surgeon, and we treat it with the maximum respect than any other ophthalmologist. So have your conjunctival cover, and that patient had this done, which was the best for her. So to summarize, I would say for any patient with a cataract and a glaucoma, no size fits all. We need to tailor management for each patient, but if there is one message I want to give, it is cataract surgery is never a cure for glaucoma. Thank you very much. I acknowledge my senior residents and residents who put these together, and of course at the Advanced Eye Center, we are able to do work because we're allowed to work so freely. Thank you so much. It's been a pleasure.
Thank you so much, Shushmita. That was a very nice talk on cataract with glaucoma, because that is often a dilemma which many comprehensive ophthalmologists and even glaucoma surgeons, I'm sure, face, whether they should do it in a single step, do it in a 2-step. So you've answered a lot of questions, I think, on that. Now over to Preeti and Ashish for the questions. Do we have some questions, I think, from the audience? Preeti,
there are audio questions.
Preeti, there's an echo coming from your...
Yeah. She has to log out from other device.
Yes. I'll do that.
Meantime, Ashish can ask it.
Yeah.
So there are 2 questions for Dr. Nayak. How do you proceed if only IOP is high? That's somebody who's asked. So basically it means that maybe the perimetry is normal, the disc is normal, and the pressure is high. So the question is addressed to Dr. Nayak, that because it's part of his talk, and how do you proceed if only IOP is high? Sir, if you can take that question, please.
Yes. So this is a very common question which is being asked, because everyone thinks that pressure is high means it has to be treated. But if, as you rightly said, that there is no other, means you added in the question that there is no disc changes and no field changes. So only pressure, means basically this patient falls in category of ocular hypertension. So earlier because I have also slightly changed now. Earlier, even 30 pressure, if everything was normal, then, I mean, other things are normal, then I never used to start treatment. But now, if pressure is more than 26 or more, means 26 or higher, then I tend to treat these patients even if other things are normal, because this is one of the risk factors, as Ronnie said in his pre-perimetric glaucoma. And also, another reason is that the high pressure has got more chances to lead to vascular events in the retina. So to prevent that, I start treatment, but I am not that aggressive as otherwise I would have been if the perimetry or disc would have shown changes. So I will not be very aggressive, but I will start treatment if it is more than 26 or high.
Dr. Sushmita and Dr. Ronnie, Dr. Ronnie can go first.
Wait to 28, and if the Pachy is in the near normal range, a treatment at that point. If the cornea is significantly thicker, then my cutoff may be a little high. But particularly anybody with an IOP of more than 30, I would treat irrespective of the corneal thickness.
Okay.
For the same reasons that he mentioned.
Dr. Sushmita?
Yeah, by and large the same, but I would also be looking at other risk factors. Family history would be one main thing, myopia, and the other thing that we've seen is that people don't report steroids. So people might be on steroids for other things, and then that high pressure might be just a consequence of that. So looking at other risk factors, but yeah, if there's only the pressure, 28, 26 is the usual cutoff to start treatment.
So you have a cutoff like Dr. Ronnie mentioned 30, Dr. Nayak mentioned 26. So the 26 to 30 is a gray zone. You have any cutoff where you would start treatment and below which you would not? Because this is what many people ask us, the general ophthalmologist.
Risk assessment, of course, like there's no normative normogram rather for the corneal thickness. But if it's average, high, or low, so if it's a thin cornea, which is usually less than 520, then the cutoff would be maybe 26. Okay. If it's a thick cornea, it's with 570, then the cutoff might be 29. So the risk assessment changes, but it is a gray zone. There is no one cutoff for every patient that comes. You can't have.
Just as a corollary,
Preeti,
how do you proceed to take?
No, Preeti, I was adding something that what Ronnie had said in his pre-perimetric glaucoma also management, that the risk factor also you have to consider. So similarly, if there are some risk factors, only pressure is high, other things are okay, but family history of glaucoma or the other eye is having something which is established glaucoma. So if that kind of risk factor or myopia or those factors are there, then yes, of course, your treatment will be a little early.
So I would say look for risk factors. If there are no risk factors, then between 26 and 30 you can observe depending on what your preference is, but do not jump to treatment just because the pressure is about 25. I think that we message. Just as a corollary, what do you do with patients who have undergone LASIK? Do you treat them at lower pressures, because their pressures are never going to be what they were before they underwent LASIK? So if Dr. Sushmita, you could just give one, how do you proceed when patients have undergone LASIK?
So we would do a complete baseline this picture, OCT as well as fields, and if everything is normal, I would take the pressure that I'm getting as a baseline and follow him up on that, without taking into consideration what it was and whether I should take that and how much was admitted. All that doesn't matter. What it is now and what the pressure is today is what I'm going to start, I'm base my decision on.
No, their corneas are always going to be thinner.
Yes.
So would you start treatment at a much lower IOP as compared to what you would do in a patient who has not undergone LASIK?
I'm always a little wary of starting treatment if the disc and fields are normal. So if the disc and fields are normal, then whatever the pressure is, I would take a lot of things into consideration before starting treatment. no matter what the pressure is. So I would observe. I think the gray hair makes us a little more conservative over time, probably.
Yes, in other words, what Shushmita is telling that even if you don't start treatment, but don't leave the patient, keep patient under observation, and don't just think that, oh, this is very simple. I have to just simply prescribe a medicine, patient will go start using it. Because if you consider yourself, if you have to use medication, and then if there is no symptom, then how many times you will trust the doctor and he will say, no, doctor has given me correct, I must use it diligently. So that way you also put yourself in the patient's shoes, and then try to consider whatever you are prescribing, because everything that you do, your every action will affect the quality of life at that particular patient. And here I will add something that means it's LASIK surgeons fortunately means when because now those patients who are coming into the age of glaucomatous damage, glaucoma development or cataract development, really we are going to be out of practice. We are not going to face that music that much as now younger generation will face, because those patients will be now coming into this age group. So ideally, anyone who is doing LASIK, they should always, according to me, they should make a complete chart of the retinal evaluation. Number 2, of their intraocular, means IOL measurement, means that those measurements even before doing LASIK may not be used that time, but at least you have those readings in the beginning. And third thing, that pressure recording before doing LASIK and after, once everything is established, means everything is, means the recovery has taken place, maybe say 2 weeks or 3 weeks later, then when medicines have been stopped, then the doctor should take 2-3 readings and take the difference, means write down the difference. What was the pressure before, but before also not only one reading, 2-3 days reading, but I am sure no one has got, LASIK surgeons don't have that much of patience, because in case if they call the patient 3 times for pressure recording, patient might get it done LASIK somewhere else. So they are in fear of losing the patient. But this, according to me, ideally it should be done. I just want comment on this thought process from Ronnie and Sushmita both.
No, I agree with you absolutely. It would be wonderful if we had that information. But at the very least, the pre-LASIK IOP and the pre-LASIK PACI, even that we don't have. And that is something that everybody would have recorded anyway. Even that one reading we don't have. I would just add that if I have a post-LASIK patient, I would do a DCT on them. I would try and measure IOP by 1 or 2 different techniques, so that it becomes a little easier to sort of adjust for the variations that we see with IOP measurements. And my cutoff, I probably would not wait till 13 post-LASIK patient. My threshold would be a little lower.
Dr. Sushmita, you want to comment?
We try to insist on a baseline disc picture as well for our LASIK patients, in addition to the intraocular pressure and PACI, of course. But we can only do that for patients who come to our institute. So I wish, as Dr. Nayak said, agree completely that if we just had this picture, we had Goldman applanation and we had pachymetry. That's all that we need to make a better judgment post-operative.
Yeah, that's true. Those are ideal conditions, and most of the time we do not have them, but we can hope for the best. And the second question is, what are the comments on unilateral trial when IOP is high in both eyes? It is addressed primarily Dr. Nayak, because it pertained to his talk. So we'll start with Sir. Do you do unilateral drug trials?
Yes, I do. That's why the slide was, but time was short, so I didn't discuss that. But I know everyone doesn't agree with that, but I do that, because not necessarily that if I start treatment in both eyes, then the variation, whatever I'm getting, the effect, the difference I'm getting is really some diurnal, because of diurnal variation or some other factor, or really the effect of medication. So that's why, and then it's not, patient is not going to go blind if you are delayed in starting treatment in other eye by 1 week or 2 weeks, because the patient, because you don't know when patient has come to you, unless it's the acute stage of glaucoma, you don't know for how long this much pressure is there, whatever you are going to treat. And as I said in my talk, that I always prefer to never start treatment on first day, because I want to have the good baseline intraocular pressure reading. So for that matter, and for perimetry, sometimes you may have to repeat perimetry 2-3 times to have a good baseline, because if the first field is normal and everything is reliable, then probably I'll take it for granted. It is okay. But if first field is showing some defect, then again I will repeat based on the urgency and the seriousness of the situation, that when I will repeat. But unless the second field also shows similar defect, I will not consider this as a good baseline parameter for this aspect. So that way even pressure and everything should be done. So there should not be any hurry to rush to start treatment.
I
This is my philosophy. I may be not 100% correct, but I do at least 80% of patients I do this.
Ashish,
Ronnie, do you do unilateral drug trial?
Yes, I do
You do?
unilateral pressure. Yes, I am a big believer in that, because I believe it does a lot of the issues that you get with diurnal variations.
Preeti, we let Ashish ask a few questions.
Yes, exactly. After this, I'm giving it to Ashish. Ashish, you can, Dr. Sushmita, you can answer that question, and Ashish, the next question, please take them.
No, I confess it's a great idea, but I haven't been able to incorporate a unilateral trial. I start with both and call them back 6 weeks and see the pressures. I don't do it.
Okay.
So you don't do that. Ashish, next question.
Yeah, I think there is no consensus as such amongst glaucoma people also. Some people do unilateral trials, some don't, and each has his or her own reason for doing or not doing it. Sir, I wanted to ask about what is the role of diurnal IOP readings in your practice as far as diagnosis goes?
To whom is the question directed?
I say, okay, no, diurnal, you see, ideally, diurnal is a very good idea. There is definitely no doubt about it. But the problem of feasibility, the question is of feasibility. Like Sushmita can get it done because she is working in an institute and she has got battery of residents, so who can do it. Because when I was also resident, that time you will not believe that we used to take pressure. Any glaucoma suspect patient, we used to do it at 4 o'clock in the morning,
Yes.
then 7 o'clock and 10 o'clock. Again 4 o'clock in the evening, 7 o'clock in the evening, and 10 o'clock at night. So that, do you think in practice, is it possible? Is it feasible? No. So, but still, just like say uniocular trial or something like that, that there's no consensus like this also, I'm sure everyone will agree that this is at least round the clock measurement of intraocular pressure is important for diurnal variation, but we have to make some compromise. That's why someone say day diurnal, or they call it on one day and say whatever is my earliest practice time, is clinic time, that time, until the end of my last appointment time. So that kind of thing. Some people say that, okay, call different timings on different days when the patient is coming for follow-up. So these are all compromise. This is not ideal. But ideal, yes, and it has got value. There's no question about it. But as I showed in one of my slides also, if everything seems to be seemingly normal when the patient comes to your clinic, pressure is under control, but still deteriorating, then that is the time, one of the factors you have to consider, that maybe you are missing out high pressure at some other time when patient is not coming.
So in the same context, is there any role for doing the supine IOP? If you have a
Sorry, can you repeat again, because the voice was not...
Supine IOP readings, sir?
IOP?
Get the question? Is there any role for doing a supine IOP reading?
Supine.
Yes.
Yes, miss. People are now these days talking about not only supine also. Sometimes they say whether you sleep on the right side of your, means mainly you are in habit of sleeping on right side or left side. That also makes some difference. But these things are, right now I don't think it is, because you see, for anything to be popular has to be convenient and easily adaptable. If you cannot do it easily, then try to find out some excuse not to do it. Means there is some sense in this reasoning, but I mean, whatever they're asking for it, but the practicality also you have to consider. So that's why it has not become popular. And just now Ronnie also mentioned about DCT in measuring as those post-LASIK patients. Yes, DCT is a very good instrument in that respect. But DCT, because as I was one of the few probably first or second to buy that, but I am not regularly using it. I don't know whether it is working, functioning well also, or that also I don't know, because it is troublesome using taking pressure routinely on DCT. So everything depends how convenient the instrument is, your procedure is, or whatever you are trying to do, how convenient it is. So that also based on acceptability is based on that.
From the point of view of the comprehensive ophthalmologist, I'd like the panelist's opinion on contact tonometers versus contact tonometers. Because sometimes it has happened with a friend of mine actually, with a non-contact tonometer, pressure came very high. She was labeled as glaucoma. She went through immense mental trauma, and then she went for a third referral and she was declared not to have glaucoma at all. In the meantime, she had already practiced going to the washroom with her eyes closed and all that sort of stuff because she thought she's going blind. And she is a very close friend of mine, so I know the mental trauma she went through. So your take on this?
I think any glaucoma expert will say that non-contact tonometer for glaucoma patient management is useless. And but in general practice, because in my clinic also I have got non-contact tonometer. Every patient which comes is subjected first to auto-ref and non-contact tonometer. But the three group of patients where I take pressure on applanation tonometer. One, if the pressure has come high on non-contact tonometer, number one. Number two, if pressure has come normal, during examination, if disc is suspected, then again I recheck it on applanation tonometer. And third category, which is a major category, that all glaucoma patients, that reading we don't take into consideration at all. All patients have glaucoma every time on applanation tonometer. I think others view also I'd like to listen, Ronnie and Susmita.
I agree with you. No glaucoma patient should be started on therapy, or therapy should be changed or modified based on a non-contact tonometry. You have to do Goldman tonometry. And even in fairly busy practices, it's possible to do it. We see close to 2,200 patients a day, but every new patient who walks into the hospital has applanation tonometry done.
Same here. I agree. I agree with both. Our entity is in the OPD, but any glaucoma suspect and any pressure more than 21, that's what we've kept there in the NCT. Unless the disc is normal, that pressure is not taken as valid. And of course, no patient is either diagnosed or followed up on the NCT.
And I think earlier the dictum was, like, I'm talking to all the 5 glaucoma experts on the panel. Earlier we used to always advise our residents, have a high index of suspicion when it comes to glaucoma. Because if you have a high index of suspicion, then you will be able to detect. I think now that needs to be moderated a bit. Okay to have a high index of suspicion, but don't go overboard also in labeling patients as glaucoma unless you are absolutely sure. And if you're in doubt, I think you should refer the patient to one more person just to get your doubt cleared. To take 3 opinions would be my take on it.
No, high index of suspicion is definitely correct approach, but don't start treatment only on suspicion.
Exactly. Because that is what is happening nowadays, Varun.
That is wrong, something which we are, everyone is going in wrong direction. Because it's very simple, just simply say, you think it's very easy. Write down one prescription, give it to patient.
Exactly.
And you are also happy, you have obliged the pharma company also. So
exactly. Also, and as you said, add a lubricant to that and the pharma companies are more than happy.
Yeah.
So that was just
especially some new medication when it comes, because what Hers showed, Repatic, I also wanted to talk about that, but because time was short, so I didn't mention that. But people, when it came into Indian market, everyone thought that now wonder medicine has come. And it is just like we are eagerly waiting for the corona vaccine. Similarly, that something like corona vaccine has come with in the form of Ripatech for glaucoma patient. But it is not that. It is just means it has got limitations. Certain use, yes, definitely it has certain advantage. And as he rightly said, that sometimes you means you have given your medication, you have no option, just add this. It may work, but doesn't mean that you add and forget about it.
Are there any more
Yeah,
questions?
so sir, as of today, Ripasudil, according to you, the message should be that it is not a first line at all. Maybe you can use it as a second line therapy.
Or even third line, maybe.
Yes, it is not the first line of treatment. That everyone should remember, because when the new medicine comes, all comprehensive ophthalmologists, they start writing this as the first line of treatment. That is number one. Number two, that this has got more side effect in the form of, mainly in the form of congestion and redness. So that we have to consider. So, but then according to me, now one place I don't know, miss, I am maybe little biased or what, but I find it more useful and probably has real indication. It's in post-operative patient, and only reason is only one. It has some anti-inflammatory effect. So, and plus also it controls, means as per the reports, controls the cystoid macular edema and to some extent corneal edema. So post-operative patients now, I blindly, my first choice is Ripatech, if I have to give any anti-glaucoma medication. So this is what maybe it's at least my personal opinion, but I have not done any research and found out, but this is what is my whatever literature, based on literature.
What is the cost of Ripatech?
400 rupees.
I don't know. How?
I think 400. Ripatech, they are promoting even for corneal endothelial damage. Those cases are also they are promoting. So maybe what sir has said, that it has both the effects on corneal endothelium also, as well as pressure reducing effects.
No, I think we should remember that neither of these are both off-label indications. For both the cornea and for CME, it has not been approved by any drug agency for that indication. There are papers which show that it works. Even I tend to use it where I have somebody with a dodgy cornea. But I personally feel it is not appropriate to market it that way because it's not actually approved for that indication.
Right.
Can we ask the next question, madam?
Yes,
it is
please.
on, my audience question is to Dr. Sushmita, that there is, this is a person who has angle closure glaucoma. More specifically, she has written plateau iris, so, and early cataract. So should we do a cat with trab or should we do only a trabeculectomy? That is the question for Dr. Sushmita.
No, the question of the trabeculectomy is whether the patient needs a trabeculectomy or not.
Yeah.
Like I said, if a patient needs a trab and has a cataract along with it, then you have to take a call on whether to take the cataract out first and follow it up with the trab, or you need to do the phaco trab. There's no question of plateau iris, whether it requires a cataract or a trab. You have to first decide whether that patient requires a trab, and a patient requires a trab for an uncontrolled pressure or a pressure which has side effects, and a disc which is not amenable to that pressure. And if you've made up your mind that that patient requires a trabeculectomy, then you need to ask yourself, in the presence of this cataract, should I take this cataract out first and follow it up with a trabeculectomy, or is the disc so bad that I don't want to risk just a phaco and then a trab later? So that would be my take. Whether it's plateau iris or whether it's non-plateau iris, you have to do a laser peripheral and take care of the pupillary block. And once that is done, then go ahead and see. But if you do a cataract only, if your gonioscopy, you have causing the raised pressure and then causing this damage, it's unlikely that just doing a cataract surgery alone is going to be of any use. But if it's a plateau iris with a primary angle closure or very early glaucoma with appositional closure angles, you might just do a cataract surgery and get away with just that and medication later. So in any primary angle closure, my message would be, there is no question of a dilemma between a cataract and a trab. The dilemma is, if the patient requires a trab, should I combine it with the cataract now, or should I do the cataract first and do the trab after that? That's the way I would look at it.
That's a very clear answer. I hope that the delegate got that answer. Ash, if you can take the next
No,
question.
but also one thing what Shushmita said is absolutely correct. But if you are doing phacotrap, then also remember this fact that in a narrow angle glaucoma, phacotrap outcome is worse as compared to phacotrap. Means in open angle glaucoma. So in open angle glaucoma, the results, the chances of success are more and the complications not that much. But in angle closure glaucoma, narrow angle glaucoma, phacotrap, success is less and the complications are more. So this fact also you have to keep in mind.
Next question.
Question is for
Ashish.
Dr. Susmita. Yeah, this question is for Dr. Susmita.
Ashish,
In written, yeah,
Ashish, your voice
I think it's frozen, yeah.
Yeah,
Is
closure.
is it okay now?
better now.
Is it okay?
Not
No,
audible.
there is actually a question from
Not
Dr. Deepak
Yeah, there is a
Rajput.
question which says, does taking an autologous superior conjunctival graft affect the outcome of future trajectomy? So it's for Dr. Sushmita. So they have not written the indication. And why was that autologous superior conjunctival graft done? Maybe for some other reason.
For pterygium, mostly for pterygium, maybe.
Yes. So maybe for some other reason. And will it affect the outcome of future trabeculectomy?
Yes, so if it's a glaucoma patient, please take your conjunctival autographs from the inferior side. Leave the superior conjunctiva as pristine as possible, because you have no idea when your glaucoma patient is going to require a trap, which is why I also put in that a clear corneal phaco, not even a scleral or not even an SICS. But if you need to take a conjunctiva, I would say that then keep the superior conjunctiva as much as possible untouched. Any procedure to the superior conjunctiva might cause fibrosis and of course would compromise a trabeculectomy later.
All right. So do not touch the conjunctiva where you're going to do a trap. Yeah. Basically, that's it.
Is my audio clear now, ma'am?
Yeah, please.
Yeah, now you're clear.
Yeah.
Ashish, go ahead.
Sushmita, I wanted to ask about in angle closure disease, where there are no facilities with a private individual practitioner, can they utilize the biometry to look at the anterior chamber depth and the lens thickness to make the decision?
Sure. On biometry, what is said is that there's something called a lens thickness axial length ratio.
Right.
So if the lens thickness axial length ratio is more than 2, which means the lens thickness divided by axial length into 10, and if that is more than 2, then it's likely that the cataract removal is going to be a little beneficial for intraocular pressure, if you need to make that thing. But even a clinical exam of a shallow AC and a thick lens, your trabeculectomies are going to be a nightmare later. So I would say that lens, it's better out before you do a trap or along with it.
Right. So basically our threshold for taking out the lens is lower in cases of angle closure disease, even if it is very early lens.
Yes, it is lower. That's true, but lower than in POAG. Correct.
Yeah, but on the other extreme, you also have people wanting to jump in and do clear lens extractions just because they are seeing the angle closure disease. So that needs to be clarified. Yes.
Removal of the lens is never going to be a treatment for glaucoma. I mean, that's bare. It's just removal of the lens. It's not going to. And the EAGLE study has received a lot of criticism. In fact, now Lancet is in trouble anyway this year. So the EAGLE was also in the Lancet. The fact that you could even think of randomizing laser fluoridotomy versus a clear lens extraction in PAC is quite shocking for all of us, most of us. But yes, please don't take out clear lenses. It's a huge thing for the patient to have a clear lens in.
So, Dr. Ronnie, you mentioned that even OCT does not have a very high sensitivity in pre-perimetric glaucoma. So which is the one investigation which you would do? Fields are normal. In many of the cases which you showed, pressures were normal. So what is that one investigation which you would do, and how would you follow up a patient with pre-perimetric glaucoma?
So what I said was you cannot make a decision based on any one investigation. You have to do a careful exam, a careful history. I think sometimes you get a clue on history alone. Or you see something on a careful evaluation, you see a little bit of pseudo-exfoliation in one corner, that can help you to make a decision of risk factor assessment. A careful disc assessment, a good disc photograph, a good baseline visual field, and baseline OCT if you have the access to it. And then you could, if you are still not 100% convinced that there is glaucomatous damage, you can follow the patient up. There is no functional damage. Waiting 3 or 6 or 9 months is not going to change anything, as long as you have discussed with the patient that this is a problem that needs to be monitored. Because they shouldn't go out and come back after 3 years with a visual field effect. That's the one thing that you want to avoid.
So follow up with all the investigations periodically. There is not one. How much weightage would you give to a disc photograph vis-a-vis an OCT?
I would always think that you should do a disc photograph before you do an OCT, because that's the one thing that technology will not change.
Okay.
A disc photograph will always be there.
All right.
An OCT, 5 years later, technology changes and you're back to square one.
Okay.
There is one question from
Ashish,
the audience. 1 minute. Preeti, there's a question from the audience from Harsha Rao. She's asking advice on treatment of unilateral glaucoma, which actually would be the same, I think, as if it was bilateral glaucoma, I assume. Because how would it change? Whether the glaucoma is unilateral or bilateral.
Yeah, the only thing that you may be a little bit more sensitive to is a drug that causes congestion. So you might prefer to use a drug that is less likely to cause conjunctival congestion in unilateral glaucoma versus bilateral. That's all.
That you would be saying from the cosmetic point of view, I think, Ronnie.
Yes, yes. But not from the medical point of view.
And the other thing, ma'am, yeah, if it was really unilateral, I would be a little more looking for secondary causes.
Yeah.
Usually primary glaucomas would not be. So, and secondary glaucomas might not necessarily be as amenable to treatment. So that's something to keep in mind, that if it's unilateral, we need to rule out secondary causes before.
And how important really is family history? Because many patients come to you and they tell you, ki, we have a very strong family history of glaucoma. So I'm very afraid that I'm going to get it.
So this is, ma'am, the one place where family doesn't include your spouse.
Yeah.
We have to tell them that a family, my husband does have glaucoma, that makes no difference. So that's one. But in the family history, the siblings' history is more important than the parents. So I would give far more importance to a brother or a sister having glaucoma than a parent. That is one thing. But family history definitely is more important than the risk of that particular patient, is definitely more than that of a normal population without a family history. So that's it. I just wanted to make that one comment, Preeti, about the pre-parametric glaucoma, that of course I would do a disc picture and OCT, yes, but I would be very sensitive to change. So whatever you do, whether you do a disc picture, you do HRT, you do OCT, you do whatever, as long as your fields are normal, you need to be sensitive to looking at change. And that to me would be another thing to be careful about. If I see change, then maybe more frequent follow-up or more careful IOP, or maybe even a diurnal. Maybe we are missing a spike somewhere. So full diurnal, maybe we are missing a fluctuation. So all those things, I would take that in consideration.
And in OCT, one thing also I will add what Sushmita said, just for the comprehensive ophthalmologist, that because she said that we are we should be sensitive to any change. But for that, it has to be done on the same machine.
Yes.
And the machine has to be facilities for registration and auto-centration, so that every time when you repeat the test, it is exactly at the same location, so that your comparison is, the change is real change, and it has to be more than the test-retest variability.
Yeah.
So those things you should know, what is the test-retest variability of your machine, and those systems, those facilities should be there, which earlier machines were not have these facilities. So every time someone is doing, some other person is doing, or same person, same machine, but still whether exactly at the same location or not, it was very difficult to get picture exactly and the measurement at the same. So this fact you have to keep in mind also.
There's an audience question for Dr. Ronnie.
Madam, we have time. Okay.
Just last question, I think. We'll take this last question. Okay, Ashish.
We actually debate about where to do and where not to do OCT for even established glaucoma. Ronnie, you have to answer this question. Will Octa help in disc suspect and normal tension glaucoma?
Okay. Will the OCTA help in this suspect and normal tension glaucoma?
OCT angio.
Yeah, OCT angio, that's right. So the thing with the OCT angio is the technology is very new. So short answer is we don't know enough yet. In selected patients, it might give you additional information, but even the normative database for many of these things don't exist. The disk measurement protocols for some of the machines have just come out. So I would say it's early days yet. I would not, it's a nice tool to have, but I don't know where exactly we'll be fitting it into our treatment armamentarium now. In future, probably it may have more of a role.
Sushmita, your inputs?
Yeah, just one comment that we need to understand that the OCT angiography is looking at moving corpuses. So even stasis is taken as a dropout. It's not necessarily ischemia. It's also a stasis somewhere. So that's one. Secondly, most of our glaucoma patients are in the age group of people who have diabetes and hypertension. Any factor which is going to alter the vascular whatever integrity of the eye is going to affect your OCT-A as yet. So as Ronnie said, it's really early days. And the third thing is we are not sure of the chicken and egg. We are not sure whether the vascular dropout is due to the laminar damage or the laminar damage is due to the ischemia. So the glaucoma bit is very, very new as yet. And I reserve my thing on it.
Okay, so I think we wind up with that because we have already overshot our time, but I think it's been a very fruitful and wonderful discussion. Thanks to our terrific speakers and the two moderators who are so well versed in glaucoma themselves. And I thank all the speakers once again for giving their time to MOS. And please let me tell the audience that look forward to our next webinar that's on 29th of August on medico-legal aspects in ophthalmology, in which the amendment to the CPA Act is also going to be discussed. We've got 3 eminent speakers for that. And we would want the audience to send in their questions beforehand so that we can address those to the speakers during that webinar. So this is a request. The secretary will be sending you out the details of the webinar. So please reply back to us. Thank you all once again. And over to Vardhaman for the formal vote of thanks.
Thank you, ma'am. So I think today we had a webinar, James in glaucoma, and of course it was wonderful to have the galaxy of speakers who had actually shared very practical tools in glaucoma treatment for comprehensive ophthalmologists. For us, target our audience as comprehensive ophthalmologists, and as has been discussed with Dr. Nayak also in the past. Probably glaucomas are treated more commonly with comprehensive ophthalmologists than the glaucoma specialists themselves. So I think today glaucoma is one of the most under or overdiagnosed disease, one of the most probably under or overtreated disease that we have, one of the leading causes of blindness in India. And I think today, right from our evaluations, which was very, very evidence-based and pre-parametric glaucoma, which was the talk given by Dr. Ronnie George, right from that to go to the medical treatment and the pulse about it by Dr. B.K. Nayak sir and Dr. Harsh Kumar, and at the end, of course, the eternal dilemma of how to handle cataract and glaucoma together by none other than Dr. Sushmita Kaushik. I think it has been a wonderful masterclass for all of us, for all MOS members and all ophthalmologists who are listening to us from all over India. And I'm happy to actually announce that over 3,300 people have watched today's webinar, and I'm very sure that they have been certainly practically benefited with that. And thank you again for all the speakers, and especially also our moderators, Dr. Preeti Madam. She has put in a lot of effort in putting all this show together. And Dr. Ashish Stool, and both of you have actually had the best questions and interactions with our speakers. And at the end, of course, our MOS leadership, Dr. Malik ma'am, Dr. Bide sir, Dr. Preetam, and all our MOS members. Thank you again, and we look forward to see you for the next MOS webinar.
And our dynamic secretary also.
Thank you, ma'am.
Good night to all of you.
Good night. Thank you
Thanks.
so much. And bye.
Bye.
Bye-bye.
Bye. Bye.
Thank you.
Dr.
Bye.
Sushmita, sir, madam. Bye. And bye, Vardhaman.
Bye. Bye-bye. Nice to see you.